Leucocytosis. Scenario: a 34-year-old car dealer presents with a short history of impaired vision in his left eye. On examination, his spleen is palpable 8 cm below the costal margin. His FBC revealed the following: hemoglobin 10.3 g/dl, normal range 12-16.5, white cell count, WCC, 348 × 10^9/L, normal range 411, and platelets 398 × 10^9/L, normal range 150-400. Introduction. How can you relate this man's symptoms of visual loss to his blood count? At this level, the high WCC can result in impaired blood flow through the capillary circulation, i.e. leucostasis. This is a medical emergency. Confirm and discuss the result with the hematologist immediately. What is the differential diagnosis at this stage? A genuine WCC of this magnitude means that the patient has a form of leukemia/lymphoma until proven otherwise. Leucocytosis much more commonly occurs as a reaction to infection, infarction, inflammation, trauma, or a drug, but in these cases it is extremely unusual for the WCC to be greater than 100x109/L. History of presenting complaint. What specific questions would you ask patients in whom you had demonstrated extreme leucocytosis? Are there other symptoms, e.g. pain in the eye or headaches? Do you have chest pain or shortness of breath? This would indicate cardiac and pulmonary leucostasis. Do you have any weakness in the arms or legs? This would suggest other neurovascular defects. Are you tired all the time? Are you experiencing unexpected bleeding or bruising? These are features of bone marrow failure. Are you in any pain? Any left upper quadrant or chest pain is related to splenomegaly, and might be present in chronic myeloid leukemia, CML. Have you lost weight? Do you sweat excessively? Do you have fevers? These are the constitutional symptoms of leukemia. Other relevant history. Ask the patient if he has been exposed to radiation or received chemotherapy in the past. These may be implicated in cases of leukemia. Examination, general features. A general physical examination is required, particularly to look for signs of infection, bleeding or leukemic infiltration. Hepatomegaly may occur as a result of sequestration of white cells in the liver. Confirm the size of the spleen, which is commonly large in CML. Look for skin or gum lesions as evidence of infiltration/granulocytic sarcomas in acute myeloid leukemia, AML. Examination, eye/neurological. Assess visual acuity and fields. On fundoscopy, look for evidence of retinal hemorrhage or central retinal vein thrombosis. Assess cranial nerves and the rest of the nervous system, including the patient's consciousness level, and if there is any evidence of confusion, can be a result of cerebral leucostasis. Investigation. Which quick investigation is required immediately? A blood film will usually differentiate between acute and chronic leukemia. In acute leukemia, the circulating cells are blasts, which characteristically have a high nucleocytoplasmic ratio and immature nuclear chromatin pattern. Chronic lymphocytic leukemia, CLL, has the appearances of mature lymphoid cells with many disrupted smear cells on the film. CML has increased numbers of myeloid cells in the peripheral blood, Fig 7, and usually presents in the chronic phase, with more differentiated neutrophils and band forms predominating in the blood film and an associated basophilia and eosinophilia, and also sometimes a high platelet count. In chronic phase CML, blast cells are rare but, less commonly, CML presence in either the accelerated or the blastic phase of the disease, when they are far more frequent. Which subsequent tests would confirm the diagnosis? Subsequent to the blood film, further information as to the nature of the cells can be gained by immunophenotyping of the peripheral blood. Monoclonal antibodies are used to detect the expression of cell markers in the population, and by the pattern of cell markers we are able to define the cell type, e.g. myeloid versus lymphoid, or immature versus differentiated, and therefore the disease. Bone marrow examination will also provide useful diagnostic information. Molecular techniques such as cytogenetic analysis and polymerase chain reaction, PCR, are used to identify specific genetic mutations that may have diagnostic importance. In CML, the Philadelphia translocation, T922, is seen, and BCR-ABL fusion transcript/gene by PCR/fluorescent in situ hybridization can be confirmed. In acute promyelocytic leukemia, FAB-M3, the T1517 translocation is seen. What other investigations would you request? Check electrolytes, and renal and liver function. Also check baseline urate, calcium, phosphate, and lactate dehydrogenase in view of possible tumor lysis syndrome. Perform a CXR, to look primarily for pulmonary infiltrates, cultures, if there is clinical suspicion of infection, and an ECG, to check baseline. Management. Request an urgent hematological opinion. The immediate aim must be to lower the WCC, which can be done by leukapheresis. This is a short-term holding measure, but may be enough to save this patient's sight pending specific treatment for the underlying condition. For sustained reduction of WCC, this patient needs chemotherapy. Keep the patient well hydrated and commence allopurinol as prophylaxis against tumor lysis syndrome in preparation for chemotherapy. Request an urgent ophthalmology opinion. Further discussion. Remember that leukemias are malignant diseases with far-reaching consequences. In initial discussion with this man and, if he wishes, his relatives, you will clearly need to say that there is very likely to be a serious underlying disease, but you must be absolutely certain that you know the diagnosis before telling the patient you've got leukemia. Ensure that if you are unable to answer the patient's questions, you refer them to someone who is more experienced in this area. If the relatives have not been involved, you may want to suggest that a relative is present during further discussions. Ideally, a counselor should be available, and relevant pamphlets and phone numbers. NB. In some patients, anemia is prominent, but be wary of transfusing blood into a patient with a very high WCC, as this may further increase their total blood viscosity and precipitate leukostatic events.